All right, now we're going to talk about respiratory. Um, what is ventilation? Well, ventilation is pretty much air moving in and out of the lungs, right? What is a clinical indicator of ventilation? It's your PaCO2, which is 35 to 45. You need to remember that, okay? Ventilation is controlled by two areas. Your central control, which is your brainstem, okay? Which, if the pH decreases, the respiratory rate increases, hence ventilation increases. In the peripheral, it's at the aortic arch, which monitors PaO2. So if PaO2 decreases, your respiratory rate increases, hence ventilation increases. Okay. Normal PaO2 is 80 to 100. Okay. So, clinical indicator of ventilation is PaCO2. Primary muscle to ventilate is your diaphragm, and the best position to ventilate is going to be sitting upright. Okay. Minute ventilation is the amount of air inhaled and exhaled in 1 minute. So, minute ventilation is tidal volume VT times respiratory rate, and that total is 4 liters per minute. Now we have dead space. Okay, we also have dead space. So dead space is pretty much, if you were to think about it, you know, it falls under the umbrella of like like VQ mismatch. Okay, so VQ mismatch for gas exchange, you must need proper ventilation and perfusion, right? Okay, so two things can happen in VQ mismatch. Shunting is when you have good perfusion, so your alveoli are being perfused, but they're not being ventilated properly. So blood is flowing by the alveoli, but there's no ventilation. There's no air moving in and out of the alveoli. Okay, commonly in ARDS, because why? There's fluid in the alveoli. The other one is dead space. You have good ventilation but bad perfusion to the alveoli. So there's physiological problem of that could be let's say a PE. Okay, that's a really big one right there. PE, it's a non-perfused alveoli with blood. So that alveoli is not being perfused, but is being ventilated. Okay. So the areas that are pretty much like dead space, would you say, is the areas that do not participate in gas exchange, right? From the nose all the way to the bronchioles, right? Gas exchange mainly happens at the alveoli. Okay. And perfusion, well, it's pretty much blood flow to the alveoli for exchange of CO2 and O2, right? Always remember, sitting upright is the best way to do it. Good lung down. Okay, if you have a left-sided pneumonia, you should be on the right side, good lung down, except if you had a pneumoectomy, right? If you had a pneumoectomy, then bad lung down to facilitate drainage. A VQ mismatch is usually, I would say ventilation is 4 liters and perfusion is 5 liters. So 4 liters over 5 liters is about 0.8. Okay. A VQ mismatch can lead to decrease in PaO2, so less than like 80, and which equals hypoxemia, and it increases PaCO2. Right, so your CO2 levels will go up. They might, you might become acidotic. Another form of shunting could be an anatomical shunt, like VSD, ASD, right? That's like another type of shunting that happens in the heart, like VSD, right to left shunt. Left to right shunt. Okay, because there's a space between the left and right ventricles. It creates a ventroseptal rupture, and so that can happen in the heart. Yes. Remember, for lungs-wise, pathological, ARDS is a ventilation problem. PE is a perfusion problem. Okay. So what do you do in this case if this is a VQ, there's a VQ mismatch? Another thing that is thing that you want to talk about is intrapulmonary shunt. When PaO2 goes down, but CO2 may still remain the same. Example of that is like asthma, atelectasis, PE. Asthma and all those status asthmaticus, asthma, you have perfusion, you just don't have good ventilation. Okay? PE is the one where you have good ventilation but bad perfusion. How do you treat this? Well, if the PaO2 is like 60 and less than 80, then you give oxygen, and that makes it go up to like 95. You can give them PEEP. What does PEEP do? Well, it keeps the alveoli open for a longer period of time, and then also it recruits alveoli, right? Bad thing about PEEP is decreases blood pressure and increases ICP. You can also introduce FiO2. Remember, keep it less than 50 is good. Greater than 50 is bad. If you keep it at 100, that can cause oxygen toxicity. When you have diffusion of oxygen, what can affect diffusion of oxygen? What can make it harder for oxygen to diffuse in exchange with CO2? Well, increased surface area tension, right? Increased thickness of the alveolar capillary membrane. Increased diffusion coefficient of gas. Increased driving force, right? So definitely increased surface area tension, increased thickness of alveolar capillary membrane. I definitely need to know that, okay? Some other concepts I think that are important to remember are, let's say you want to talk about respiratory acidosis, respiratory alkalosis, right? So we know respiratory alkalosis is early respiratory failure, right? This is what happens before, like, let's say patients going into respiratory failure. First thing is respiratory alkalosis. First, they start hyperventilating first, the increased respiratory rate, right? This is when they have low CO2 because they're breathing out so much CO2. So they have hyperventilation and hypocapnia, okay? And then eventually they go into respiratory failure, late respiratory failure, which is respiratory acidosis. This is when they hypoventilate, right? And then the CO2 in the blood goes up, so they have hypoventilation and they become hypercapnic. This is like in ARDS, especially in ARDS, in that situation, okay? The other one, now we're going to talk about mainly metabolic acidosis and alkalosis, okay? We're going to talk about those. So metabolic acidosis, the thing that you can remember is mud piles. So in mud piles, you can just sort of write out mud piles. So M-methanol, the U is uremia, or uremia, think about the kidneys, okay? Like BUN, okay? And the D, think about DKA. DKA, we already know we get metabolic acidosis and DKA, right? So you can think about it that way. I, ionized, but L, lactic acidosis, right? So remember that, lactic acidosis, okay? E, ethanol, but S, ciliates like aspirin. So the biggest ones you want to remember is uremia, right? BUN, elevated BUN, DKA, lactic acidosis, aspirin, okay? Those are the big ones. Then if you have metabolic acidosis, you know your anion gap is going to be higher, greater than 12, right? To measure metabolic acidosis is parentheses, sodium plus potassium, right? And then plus parentheses, Cl minus HCO3, okay? Metabolic alkalosis, number one things are vomiting and diuretics, so fluid loss, not diarrhea, vomiting and diuretics, okay? Just know that it has to do with fluid loss. Either you vomit it or you're peeing it out, diuretics. Other ones are like NG tube antacids. Okay. So what is capnography? Well, capnography, its ability to detect CO2, which is 35 to 45, after a patient is being intubated, right? After the patient has been intubated. Right, if the patient is hypoventilating, well, then the EtCO2 goes up, right? If the patient is hyperventilating, the EtCO2 goes down, right? This is commonly, the capnography is commonly used for weaning a patient off a mechanical ventilator to see if the patient has any, if they're retaining CO2 or expelling CO2. Commonly used during head injuries, sedation. Sometimes the ET tube can go in the right lung or can get dislodged. In this case, you will not have any capnography detection. There will be a flat line, okay? All right, so what's the next thing we can talk about? Well, we could talk about, let's talk about hemoglobin. Right, what we could talk about, before we talk about the hemoglobin curve, we'll talk about oxygen delivery to meet tissue demand at the cellular level. There's anaerobic, so there's aerobic where you have oxygen. There's anaerobic where there's no oxygen, that leads to lactic acidosis and metabolic acidosis. We already know SaO2s, you need to be greater than 90, SvO2. SvO2 is the most sensitive indicator of oxygen consumption at the cellular/tissue level, which is at 60 to 75%. DO2, which is oxygen delivery, that's affected by, we already talked about that, right? Your CO2, your like PaO2 from the lungs, and your hemoglobin, right? Okay. And normal is about 1,000 mLs per minute. Tissue consumes about 25% of the oxygen delivered. We already know that, because if you have about 100 going SaO2 going to the lung, to the tissue, 25% gets used up, and SvO2 is highest at 75%, right? Okay. The VO2 is the actual O2 consumption. Okay, so that's what you need to know. The VO2 is the actual O2 consumption, which is about, if DO2 is oxygen delivery, which is about 1,000 mLs per minute, the VO2 or O2 consumption is about 25% of that, which is 250 mLs per minute. Okay, so that's a good way to remember it. Obviously, we talked about how SvO2 can increase during sepsis because the tissue cannot use up oxygen, and SvO2 decreases because if the tissue uses up too much oxygen during like hypotension, ARDS, decreased cardiac output, hemorrhagic shock, bleeding, anxiety, right? So the oxygen hemoglobin curve, in the x-axis, you have the PaO2. On the y-axis, you have hemoglobin and SaO2 binding, right? So if we talk about what's happening on the left side, well, if you shift to the left more, you go left and up, pH is up. Okay, you go left and up, pH goes up, becomes alkalotic. Okay, if the pH is going up, your H plus is going down, right? That means if you go to the left, that's bad. Left and up of the pH, that's bad, because that means hemoglobin is binding to oxygen. It's not letting go of oxygen, it's holding on to it longer. So if the pH is up, everything else is down. So temperature is down, D23 DPG is down, your PaCO2 is down, right? The reason your D23 DPG could be down is because like RBC perfusion or hypothyroid. Okay, that's one way to remember. To the left, bad. Left and up, that's bad. Everything else is down. Then you go to the right. If you start going to the right, if the curve shifts to the right and then goes down, your pH is going down. To the right and down is good. That means your hemoglobin is disassociating with the oxygen, it's separating itself with the oxygen, releasing more oxygen. Since the pH is going down, everything else goes up. Like temperature goes up. D/2, 3, D/3, DPG goes up, PaCO2 goes up. Right. One thing, a keynote if you want to remember is, let's just say your SaO2 is around 90%, which is normal. If your SaO2 is 90%, your PaO2 is about 60. Okay, that's a keynote. Carbon monoxide. Hemoglobin holds on to carbon monoxide longer and stronger than oxygen. In this case, if somebody has carbon monoxide poisoning. Normal levels are usually like less than 5%. Truckers have about 5 to 15. Mortality happens at greater than 50. Your goal is to decrease that carbon monoxide to like around the area where the truckers are, 5 to 15, less than 10%. So you give 100% FiO2 in a hyperbaric chamber. All right. So now we're going to talk about ABGs. Let's talk about ABGs. So ABGs, right? So pH is 7.35 to 7.45. CO2 is 35 to 45. Bicarb is, which is ACO3 minus, is 22 to 26. So ABA, BAB. Okay. Notes, CO2 R equals lungs. That can change within minutes. HCO3, bicarb, kidneys, can take hours and days. The least compensation needed is respiratory alkalosis, right? Because, right, remember, think about it. If somebody's having anxiety, they're breathing fast, they're becoming alkalotic, you can calm them down, right? You can calm them down. You don't need to give them meds, you can just calm them down. Okay? So, just know, keynote, full compensation occurs when pH is normal, 7.35 to 7.45. Okay? If the pH is not normal, it's already uncompensated. And then you move down next, okay? So let's look at it, right? If pH is normal, you know it's compensated. And then you look at the PaCO2, then you look at CO2 and HCO3. One of those have to be abnormal then, right? If pH is abnormal, then it's uncompensated. and only one of the either CO2 or HCO3 is abnormal, the other one is normal. Okay, if the pH is abnormal, you still think, okay, well, it's still uncompensated, but let me go to the PaCO2, the CO2 and HCO3. If the CO2 and the HCO3 are on opposite ends, right? They're on opposite ends and they're not within like normal ranges, then it's compensated, partially compensated. Full compensation only happens when pH is normal. So let's say your pH is 7.36, your CO2 is 48, and HCO3 is 24. Well, look at the pH. Is it compensated? Well, pH is normal, so it's compensated. Okay, so let's look at CO2 and HCO3. CO2 is 48. That looks like it's acidotic, yeah. And HCO3, it's between 22 to 26. That's normal. So we know that this is compensated respiratory acidosis. Right, good. Now let's look at pH 7.26, PaCO2 35, HCO3 16. What is the pH? 7.26. We already know it's uncompensated. Okay, now look at the CO2 and the HCO3. CO2 is 35. CO2 is 35. That's within the normal range of 35 to 45. Okay. Let me look at CO3. 16, 22 to 16. Wow, it's less than 22. So that's acidotic. So we may have uncompensated metabolic acidosis, right? Right? Yeah, because if it was compensated, either your pH was normal or your CO2 would be on the opposite end, which is not of the HCO3. Now this is a good one. So pH is 7.30, CO2 58, HCO3 30. pH 7.30, well, it definitely looks like it's uncompensated, but let's look at CO2 and HCO3. CO2 is 58, that's acidotic. HCO3 is 30, that's greater than 26. That's alcohol, that's like out of the normal. So the CO2 and the HCO3 on our opposite ends. So this now switches from uncompensated to partially compensated respiratory acidosis. Okay, good. Now, if we're talking about plateau pressure, we're focusing on status compliance. Okay, it's like patient holding on to their breath, right? Commonly seen in ARDS, when they're trying to like maybe see if the patient's ready to be extubated. You want it to be less than 30. If the plateau pressure is greater than 30, all you need to remember is decrease the tidal volume, the VT. If you decrease the tidal volume, the plateau pressure will go down. That's a key note. Okay. All right, so the next thing we're going to talk about is lung compliance. Lung compliance. Talk about lung compliance. So lung compliance is focusing on the elasticity of the lung, right? So we have static compliance and dynamic compliance. We talk about how static is, the S is for lungs, right? So we're talking about any problems with the lungs. We're talking about ARDS, pneumonia that can cause a decrease in the lung status compliance, right? When static is decreased, dynamic is normal. They're all whichever one's decreased, the other one's normal. Okay. It's calculated by the plateau pressure. Okay. With dynamic, the A in dynamic, think about airway issues, asthma, status asthmaticus, okay, atelectasis, that increased respiratory rate. So a decrease in dynamic compliance causes a normal static compliance. Either way, both of these, whenever compliance decreases, whether it's static or dynamic, your workup breathing increases. Dynamic compliance is calculated by peak inspiratory pressure, PIP. And plateau pressure is for static. Okay? Now we're going to talk about acute respiratory failure. Okay? So acute respiratory failure, your biggest thing is a problem with a rapid onset or rapid problem with issues with exchanging O2 and CO2. So there's two types, right? You have two types of issues you're going to have. You're going to have where your PaO2 is going to be obviously less than like 80, right? It's going to be less than like 60. In this case, well, normal PaO2 we already know is like 80 to 100, but in this case, in acute respiratory failure, your PaO2 is like less than 60. You will have hypoxemia. All right? And the other type is, well, you have hypercapnia. Your PaO2 is greater than 50. Okay? So in type 1, if your PaO2 is less than 60, it's mainly because you have poor oxygen exchange. That could be due to fluid, pneumonia, ARDS, pulmonary edema. In type 2, hypercapnia, you have PaO2 that's increased, greater than 50. Well, it's not really related to fluids. It could be related to more of like COPD, asthma, increased ICP, a weak diaphragm. Okay? In acute respiratory failure, your early symptoms, you're more looking at like increased respiratory rate, tachypnea, right? You're talking about decreased LOC. The late hallmark sign is hypercapnia, right? Where you start retaining more CO2 in the blood. You start becoming more respiratory acidotic, right? What are some of the reasons why someone would have hypoxemia, right? If we already talked about like why we talked about PaO2 less than 60. We talked about three reasons for hypoxemia. It could be hypoventilation, right? You're not ventilating enough, right? So, or why you would have increased PaO2, right? Is like hypoventilation. You're retaining more CO2. Head injuries, ICPs, sedatives, or you have a VQ mismatch, like you have pneumonia, PE, sepsis, decreased oxygen delivery, DO2 is less than 1,000 mLs per minute, like due to hypotension, right? So how do you diagnose? How do you diagnose acute respiratory failure? Well, you do ABGs. It's more likely going to show PaO2 less than 60, PaCO2 greater than 50, pH 7.30. It's acidotic, right? 3 causes of ARFs. We talked about hypoventilation. We talked about VQ mismatch. We talked about decreased O2 delivery to tissue, right? The goal of treating acute respiratory failure is to what? Well, do everything what we did the opposite. So get the PaO2 to be greater than 60. Get the PaCO2 to be less than 50. Get the SpO2 to be greater than 90, and the pH, make it more normal, greater than 7.30. Okay, so you can do for airways, you can do like bronchodilators, right? You can do bronchodilators. Non-invasive, you can do like a nasal cannula, high flow, CPAP, BiPAP. You can also go invasive, where you can do mechanical ventilator and intubate the patient, this is when the patient's starting to have a decreased level of consciousness, respiratory arrest, pH starts becoming less than like 7.30 almost. You can also improve oxygen delivery. You can do FiO2. You can increase the FiO2 to get the SaO2 to be greater than 90%. So go up on the FiO2. Okay, so you can do that. What you need to know is that when you breathe air in, that's your FiO2. Normal air that we breathe in humans, the FiO2 is 20%. Okay, that goes to the lungs. All right, your PaO2 is the actual oxygen mixed with the arterial blood. Your SaO2, which is greater than 90, is the oxygen bound to hemoglobin. Okay, just a little quick pathway. So now, since we're already talking about a little bit about we're already talking a little bit about non-invasive ventilators. We're talking about CPAP and BiPAP. When do you commonly use this? Well, when PaO2 goes down less than 60 to 80, you become hypoxemia and you have respiratory failure. So one thing you need to remember is CPAP is one setting, FiO2 plus PEEP. CPAP is commonly used for COPD, patients with sleep apnea, obesity, pulmonary edema, right? BiPAP, the word bi, it's two separate settings. You still have FiO2 plus PEEP, but now you also have the option of IPAP and EPAP. IPAP is ventilation. EPAP, oxygenation. Okay? Both improve oxygenation and ventilation. Both can help decrease preload and afterload. However, you need to avoid both of these options. If the patient's hemodynamically unstable, they cannot protect their airway, they have high risk for aspiration, and they have decrease in LOC. That's when you want to talk about maybe mechanical ventilation. Okay. So next thing we're going to talk about so I say we talk about we could talk about ARDS. We could talk about ARDS. Let's talk about ARDS. We can talk about ARDS. Well, what is ARDS? Well, we know that ARDS is, ALI is the first thing, acute lung injury. Acute lung injury happens first, then it goes to ARDS, right? In ARDS, you have increased capillary permeability, right? You have increased capillary permeability. That's how fluid gets into the lungs, right? Then you have damage to the type 2 alveolar cells. In ARDS, you also have decreased compliance and decreased surfactant, okay? Stages of ARDS are EPF, exudate, about less than a week. Proliferative, about a week. Fibrotic, about 2 weeks. Okay. Risk factors for ARDS, number one cause is shock. Then you have TRALI, TRALI, trauma, sepsis. Okay. What is the criteria? Okay. What is the criteria to be ARDS? 3 plus 1. Okay. So out of the 3, you have these: bilateral lung infiltrates on the chest X-ray, acute onset within a week, your PaO2 less than 18. I have to review that PaO2 one. But yes, those bilateral infiltrates, acute onset less than a week, PaO2 less than 18. The plus one is if the PaO2 over FiO2 is less than 200 with a PEEP of greater than 5. Less than 200 with a PEEP greater than 5. That's mild. Severe ARDS is when the PaO2 divided by FiO2 is less than 100. That's severe ARDS. And remember, the PaO2, whatever you get, you divide that by the FiO2. If it's like 80%, then it's 0.8, okay? Some symptoms of ARDS is increased respiratory rate, crackles, refractory hypoxemia. Okay, remember your PaO2 is very low. Okay, decreased lung compliance, right? Your lungs are very stiff. Early, you have respiratory alkalosis. You eventually start having respiratory acidosis. That's late. Okay. How do you really diagnose ARDS? Well, with the P over F ratio. We talked about that, right? Less than 200 with the PEEP greater than 5. Chest X-ray will show bilateral infiltrates, right? Severe ARDS we talked about, less than 100 with PEEP greater than 5, right? We know that to treat ARDS, mechanical ventilator, right? In ARDS, you need to know, usually PEEP is around 15. The higher you go up on the PEEP, the higher risk you have for barotrauma, okay? Like popping the lung. PEEP is good for recruiting alveoli, opening up the alveoli, especially during expiration, right? PEEP, however, the higher you go up on the PEEP, you're going to have high risk for dropping the blood pressure and increasing ICP. For tidal volume, VT, usually, they recommend 6 to 8, but for ARDS, you do 4 to 6 mLs per kilogram. Put it on low tidal volume and low set rate, okay? And then your goal is to have an end inspiratory plateau pressure less than 30, right? Remember, if it goes up greater than 30, you go down on the VT. One thing you need to know that let's just say, well, how do we determine if we go up on the PEEP? Well, if the P over F ratio is low, the lower it is, the higher you have to go up on the PEEP, right? So if it's like PaO2 is 42 and the FiO2 is at 100, well, you're already technically at 42. Your P to F ratio is 42. That's way less than 100, right? So you're way past severe ARDS. Now you got to go up on the PEEP. So key things to know. If you want to change plateau pressure, you go down on the tidal volume. If you want to improve your P over F ratio, if it's too low, you go up on the PEEP. Okay? All right. So extreme, how do we look at tidal volume? Well, it's mainly your patient's predicted body weight. We go off of patient's predicted body weight. Now, if it was extreme rescue, you prone the patient early, You do neuromuscular blockers and do train of 4, so it's 1 to 2 twitches out of 4 per minute. You protect the eyes. You can do inhaled pulmonary vasodilators like nitric oxide or epoprostenol, right? Or ECMO. Remember, with ARDS patients, you do not give them steroids. Do not give them steroids, okay? Another thing that some doctors will try to do is permissive hypercapnia, which is like, hey, let's try to lower the tidal volume and see if the CO2 goes up, okay? Complications of ARDS, you're looking at MODS, death due to MODS, barotrauma due to increased PEEP, secondary infections, PEs, okay? So a couple things. For patients that are ARDS patients, you want to, and they're ventilated, you want to give them a high protein, high fat diet. No carbs. Why no carbs? Because, well, carbs increase CO2 levels. That's why. Okay. Tidal volume, like we talked about, is predicted body weight. It kind of focuses on height, weight, and gender. Okay. Okay, so that was good.